right, we're going to go ahead and get started. Thank you all for joining us tonight. I'm Hannah Collins, and we're here with Dr. José Espinel speaking about fast and easy hernia repairs. Dr. Espinel is a board certified general surgeon. He earned his medical doctorate from Universidad Católica Santiago in Ecuador and completed his residency in general surgery at St. Barnabas Medical Center in Livingston, New Jersey. Dr. Espinel completed a fellowship in minimally invasive surgery at Bay State Medical Center in Springfield, Massachusetts, and now performs robotic surgery. Dr. Espinel enjoys working for Tanner, where he practices at Carrollton Surgical Group in Bremen, Carrollton, and Villarica. Dr. Espinel, whenever you're ready.
Hey, Hannah, well, thank you very much for that introduction. And it's always a pleasure to be part of this community lectures, which I think they're very helpful. Today, I'm going to talk about one of my most fascinating topics, which is hernias, which I do have a very much interest in this type of disease. So I'm going to share a little PowerPoint presentation, which it's going to kind of enlighten a little bit more the topic in here. So you give me a second. Hannah, is that looking good there?
Yes, I can see it.
Okay, good. Just want to be sure. So the topic for today is fast and easy hernia repair. First, to understand what a hernia is, we have to make it to have a definition about it. And hernia is when an organ, intestine, or fatty tissue squeezes to a hole from a weak spot from the muscle. And this hole could be localized in any part of the abdominal wall, and that protrudes to the outside, and those are usually visible lumps. And there's another interesting part, hernia, which I also like to fix, which are the hiatal hernias. And we're going to talk about that because those are the ones are between the belly cavity and the chest cavity, and you don't really see them, but you're going to have some symptoms from it. So as I explained it before here, once you have a hole in the muscles, then any organ from inside that cavity is going to protrude through it, and then you're going to feel a lump in that area. And that's how you patient will kind of have an idea that, oh, I'm developing a hernia. So I'm going to just go a little more in depth regarding what a hiatal hernia is. This is the ones, once again, that you're not going to see any protrusion coming through your abdominal wall. This is actually a hole between your abdominal cavity and your chest cavity. To try to make it a little bit easy to understand, the abdominal cavity and the chest cavity are divided by a muscle called the diaphragm. The diaphragm, which is the most important muscle for respiration, and we all have a natural hole in the middle of the diaphragm, and this is called the hiatus. And that's where the hernia, the term hiatal hernia comes from. The hiatus is a natural hole that allows several structures from the chest to go through the abdominal cavity. There's several structures that go through that hole, but there's two major ones that that you will understand a little bit better. One of them is a vessel called the aorta, which is this big vessel comes out of the heart, gives some vessels in the chest, then it goes down through the hiatus into the abdominal cavity, and then gives arteries to supply your intestines, your colon, and keeps them going down and divides into your legs, into the arteries for your legs. So big vessel has to come through this hole. The other important organ that comes through the hiatus is called the esophagus. And the esophagus is what we all know as a term of the food pipe, which is a tubular structure. It's a long tube that is made out of muscle and basically connects the mouth with the stomach. So you chew your food in your mouth, then you swallow it, and the esophagus, the food pipe, comes from your neck down into your chest and come through the hiatus to plug into the stomach. When this hiatus, when the hiatus size increases in diameter, then any organ that is inside the belly cavity can go into the chest. And one of the things are in disadvantage for people who have hiatal hernias is that the chest cavity is a negative pressure chamber. Every time you take a deep breath, you're basically sucking into the chest any of the organs in the abdominal cavity. Well, which is the first organ that is attached to the food pipe or the esophagus is the stomach. So the first organ that will go into the chest, it will be your stomach. So there are different types of hiatal hernias. I'm not going to get into much of details, but as you can see here on this slide in your right side, if you're looking at the monitor, you see there are type 1, type 2, and type 3. There's actually a type 4 as well. And the higher the number is basically the worst type of hiatal hernia that the patient has. And as you can see in the picture here in the middle, one of my patients, what you see there's a big hole, that's the big hiatus. And that organ that you see way deep in the hole is the stomach. This patient had the entire stomach within the chest. And you can also see part of the small intestine into that hiatal hernia. So then the big question is, what causes hernia? Why some people have it, when some people don't have hernias? And just to go through some of the causes, I can just tell you that it's a multifactorial situation that people have hernias. That means there's more than one reason why you could develop a hernia. And here are several of them, and going through some of them. One will be obesity. And just to common sense is common sense. If you increase the pressure in your belly cavity, inside the abdominal cavity, and you have a weak area in your muscle, then because of the increased pressure in your belly cavity secondary to obesity, then that weakness can become a hole. If you have if you lift heavy objects at work or do a lot of heavy objects at the gym, that will also could be a cause for developing hernias. Once again, constipation, if you're increasing too much your abdominal pressure, that will make it. People who have COPD, asthma, smokers are going to cough and sneeze all the time, poor nutrition, smoking for sure, pregnancy, it's the same concept as obesity. Pregnancy will increase your intra-abdominal pressure and increases the chance for hernias. In pregnant women, it's very common to have umbilical hernias, which are hernias localized at the level of the umbilicus. And there are also other causes like genetics. If your father, your mother had a hernia, then most likely that could go into your genes and you can develop that. And there's some diseases that make the abdominal muscles weak. So those are some of the causes. Let's talk a little bit about hiatal hernia, which is different, right? I'm trying to separate these two things because there are hernias, and I'm trying to put them all into one presentation. But as we talked, the hiatal hernia has different type of symptoms. You won't feel a bulge or anything coming up here into your chest, but basically what you have is you have symptoms of reflux disease. That is the most common presentation. And those symptoms could be heartburn, regurgitation, which means the acid coming all the way to your mouth. You can have difficulty swallowing, which is called dysphagia. And that is because the stomach, when it goes into your chest, it kinks your food pipe, and that makes things worse for the food to go down to your stomach. And the other thing is chest pain. So one of the typical presentations is, and that's the reason for this slide, is that it can present like a heart attack. So people will have some pressure sensation in the anterior aspect of your chest, and they usually go to the emergency department. They do cardiac workup, they do an EKG, they look at your cardiac enzymes, and then as being that there's nothing wrong with your heart, and they investigate a little bit more with some imaging studies that we talked a little bit about in the next slide, and they figured out that your stomach is in your chest cavity, producing the symptoms mimicking like a heart attack. So let's talk about symptoms. So what are the symptoms of the patient? We just talked about symptoms for hiatal hernia, so we're going to leave that on the side. Let's talk about now symptoms of the abdominal wall hernias, the ones that you feel a bulge. So it could be a bulge in your groin or into your scrotum. Those are called the inguinal hernias. They're down in your groin. You can have some burning sensation or pain itself at the hernia site. And the other thing that you can feel is some type of weakness or pressure sensation where the hernia is. Now, the hernias, and I'm going a little bit backwards, they are named depending of where they're localized. So if you have a bulge or hernia in the belly button area, area is called umbilical hernia. If you have a bulge or a groin hernia, is called inguinal hernia because it's called the inguinal region. And there's some other hernias that come and protrude through a previous incision. So if you have a cholecystectomy done or a colon surgery done, and they've done an incision in your abdominal wall, and you have a protrusion through that incision, that is called an incisional hernia. So how do we make diagnosis of hernias? And once again, always dividing the abdominal wall hernias and the hiatal hernias. The abdominal wall hernias are basically made with a physical examination. Physician has to use their finger, find the area where is the hole, make the patient do what we call a Valsalva maneuver, which is to increase the pressure in your belly cavity by sneezing, coughing, straining. And once you have the finger in the hole, then the patient who's doing the examination should feel that an organ is pushing through that hole. And that makes basically a definitive diagnosis. Now, there's an exception for this rule, is that if we have a patient that has a body habitus that has a lot of fat, especially in obesity, sometimes the physical examination is not too reliable. And that's when we order other testings, like could be some ultrasounds or CAT scans of the abdominal wall. Hiatal hernias, on the other hand, the hiatal hernias where your stomach is in your chest cavity and produces symptoms of reflux, then you have to do a diagnosis through an upper endoscopy, which is called an EGD. This is performed by gastroenterologists or surgeons, where they put a camera, a long tube in your mouth while you're asleep under sedation, so you won't feel or remember anything. They go down to your mouth, your throat, go into the stomach. And what we do is this tube that is going down, we call it retroflexion. So we kink the tube in itself, and we're looking up into your stomach, and then we can see the hernia. And there's some other special x-rays that we can order to the diagnosis. First of all, a plain x-ray can show the stomach behind the heart, and that can be picked up, which is sometimes a little hard. But the other special x-rays will be what we call a barium swallow. What we do is we give you special contrast called barium. It's a white liquid. You drink it, and while you're drinking it, the radiologist will do special x-rays at that time, and then that will show us that the stomach is in the chest, because you drink the contrast, and the contrast will outline the shape of the stomach. And as your stomach is in your chest cavity, it will show it up. So then we go through how do we repair hernias. Once again, we're going to divide both of them, but in general, both of the type of hernias, abdominal wall hernias or hiatal hernias, can be repaired with an open approach. That means we make a big incision. And the other approach is what we call a minimally invasive approach. What is a minimally invasive approach? Where we make little incisions instead of big cut to repair the hernia. So let's start with the abdominal wall hernias. You can use an open approach, and we sometimes select an open approach. For example, if you have a small umbilical hernia, which is the protrusion through your belly button. If it's a small hernia, sometimes we prefer just to do an open approach, because we can make a small incision and fix the hernia through that technique. When the hernias are bigger, then we try to recommend a minimally invasive. Why? Because when we make big incisions, there's a higher chance for infection. There's a higher chance for mesh infection. The patient is going to experience more pain. There is a cosmetic difference as well, having a big cut with little cuts. And that's why we decide as surgeons, if we're going to have to make a big cut, if the patient qualifies to do it, try to do it through little incisions. And the little incision comes down into, we can do it laparoscopically, which is basically you make the small incisions and you put some stiff instruments and you do the operation with those stiff instruments. Or the latest technology, which is not too latest because it's been around for around 20 years, is robotic surgery. And the difference with the robotic and laparoscopy, if you still make small incisions to put some instruments that are controlled by the surgeon. It's not a robot that you just, press a play button and the surgery's going to be done. It doesn't work that way. It's called robotic because through a console, these instruments can be handled by the surgeon. And the difference in between laparoscopic and robotic is that the instrument that you're putting inside the patient's cavity, those instruments can rotate more than the human wrist. So you can do more precise operation with robotic surgery. That's one of the difference. The other difference is the robotic camera has a 3D perception, and the laparoscopic technologies just have a 2D perception. Laparoscopic is just like watching TV, watching the operation through a TV monitor, so you don't have any depth perception. Now, that was with the abdominal wall hernias. The hiatal hernias, on the other hand, basically, yes, can they be repaired open? There is an open repair, but nowadays the gold standard is to perform a minimally invasive approach, laparoscopic or robotic. So I was just basically went ahead and talk about this minimally invasive approach. Once again, smaller incision, less carrying, faster and more comfortable recoveries. And that is the advantage of doing little approaches. Here is a cartoon of how to fix hiatal hernias. These are the top ones, is 2 cartoon pictures, and you can see there how the stomach has been pulled down into the belly cavity. Then you can see a cartoon of how do you put sutures to close the hole. The bottom 2, there are pictures of patients that I've done surgeries. You can see there that the hole of the hiatus, that kind of V-shaped thing, hole there. And then in the right side, in the bottom part, you can see how that hole is already closed with some sutures that you see there. And that's how basically we repair the hiatal hernias. This is how robotics technology looks like. Here on your left side of the picture, you can see the operating table where the patient lays down. Then next to it, you see those arms, which is the robot where we put the instruments. And back in the back, you can see a console. You see there the surgeon sitting down into the console, and his head is looking through that monitor that is a 3D. And the other advantage you can see there, the surgeon is in the sitting position performing the operation. The other important thing about robotic surgery is the surgeon controls all the instruments, including the camera during the operation. So you don't need an assistant to perform the operation, which through laparoscopy, you do have to do that. And the picture on the left is actually the robotic that we have at Tanner Healthcare Systems. That is the XI version of the Da Vinci robot, which is the latest technology in robotic surgery available in the world. So then the question will be, so how do we prevent hernias formation? Well, to prevent a disease, then we have to go to the causes of the disease, and we talked about that. So want to prevent it is to avoid obesity. So maintain a healthy body weight, avoid straining, so try to avoid constipation, and for that you have to eat a lot of fibers, so fruits, green vegetable, whole grains, that will help that. The other thing that we talked about is heavy lifting. So yes, some people, it's part of the daily living because of their job duties. It's always a correct form to lift heavy objects. If there's too heavy, use help other people to help you with lifting heavy objects. And the other thing is that you can prevent is smoking. We talked about smoking damage to tissue. It makes it weaker, and it also, in the cases for hernia, makes people cough, and cough is a risk factor for developing hernias. So these are kind of the references where you can obtain some more information about our surgical practice and surgical diseases that we can help you with. There's a QR code. If you take a picture of that, then you can get a little more information. And that is the end of the presentation. If you have any questions, I'll be more than happy to answer them. Thank you very much.
Dr. Espinel, can any certain workouts make hiatal hernias worse?
Workouts. So let me just go this. And So yeah, so workout, same thing. So heavy lifting definitely is gonna make hiatal hernias worse. So anything that really puts a lot of increase your intra-abdominal pressure, it will increase the chances for hiatal hernias, abdominal hernias. So to be specific, anything that is going to strengthen your abdominal wall. So abs, pull-ups, sit-ups. Those are the ones that I can think more. Lifting heavy objects like plain lifting, right? Bench presses and things like that. Yes, you can make hiatal hernias worse.
What determines using mesh and not using mesh?
That is an excellent question. I knew that was going to be a big question here. So I'm going to give you the scientific answer for that. And obviously, the scientific, I mean, what is in the literature and what is the recommendation. And then I'll tell you practical indications for it. So the literature says that any hernia that has a diameter of 2 or more centimeters, then the recommendation is placing a prosthetic material, in this case, mesh, right? And the reason is because the papers that have been studied out there, they show that if you repair a hernia that's 2 centimeters or more and just put sutures, then the incidence for recurrence, which is the hernia is going to come back. And the papers are vary a lot, but there's papers that says that it can recur between 20% to 70%. And there's a lot of papers, and we can talk about that. But that's a big, wide range. Usually I tell patients, if you do not put mesh in a hernia that's 2 centimeters, your chances for it to come back is like flipping a coin. In other words, probably 50-50 chance. So it's very hard to find people with hernias less than 2 centimeters. That's number one. And then the other indication to put mesh is in people who has a high risk to recur the hernias. So that means that you fix the hernia with sutures and they have a high chance to come back. The 2 most common reasons why hernias come back, even after you fix them, are number 1, obesity, and number 2, smoking. So if I have a patient that have a hernia that is, let's say, 1.5 centimeters and is obese or smokes, right? I will put a mesh in that patient. So because I know that the chances for that person to come with a hernia back are going to be higher. Now, in the hiatal hernia world, which is different, once again, we're trying to divide those 2 things, abdominal walls and hiatal hernias. Hiatal hernia is actually interesting. The literature out there says that patients who get a hiatal hernia repair, and don't get afraid about this number, they have a 50% chance for the hernias to come back. Now, I just explained to you that a hiatal hernia, by definition, is if any part of the stomach goes into the chest. The good news is that from those 50% patients that develop a recurrent hiatal hernia after they got it fixed, and that's why we do a test, that swallowing test at a year after hiatal hernia repair, and you have a recurrence, 50% of those 50%, almost 80 to 90% of those patients will have a very small hiatal hernia. That means that probably a 1 or 2 centimeters of stomach is in the chest cavity. And by definition, that's a hiatal hernia. So you have to call it that they have a recurrent hiatal hernia. But 90% of the patients will have that and they will not have any symptoms. So you're going to have to get it fixed again. I'm going through that is because you talk about mesh. In the hiatal hernia, there's a lot of papers out there where people have been routinely putting mesh to fix hiatal hernias, and some surgeons don't put routinely mesh. And when you see those numbers in those papers 5 years out, 5 years after people get hiatal hernia repairs with mesh or without mesh, the recurrence rate, that means if the hernia comes back, is basically the same, which is around between 30 to 50% chance. So a lot of the surgeons, we think that, okay, if the outcome is going to be kind of the same, then why put a mesh in everybody? So there's some surgeons like me in this particular case, and I'm more a selective type of person, a surgeon, to put a mesh in the hiatus. And that's to talk about, about mesh.
Okay, and somebody said, I have had 2 previous and I have another in the same area. I think they're talking about cases that have used mesh. Would that be a candidate for a robotic?
So, well, it's kind of question. The answer for that is going to be the patient has to be evaluated, right? The robotic technique has a role, but it's not that everybody will qualify for robotic surgery. So that person needs to be evaluated and decide. I can just tell you that if this is abdominal wall, I'm assuming this is abdominal wall hernia recurrence after 2 repairs, then you have to start thinking about why the hernia has recurred. And I just talked about it. The 2 most common reasons are obesity and smoking. So that question to that person will be, do you smoke? Number 1. Number 2, what is your BMI, which is body mass index? See how if this obesity or not. And what I try to tell patients is when they're getting a hernia repair in one mesh, first without mesh, then we go back and they put a mesh, and they come back and get another mesh placed. And you started getting into this, keep on putting mesh and mesh and mesh. You really have to get a thorough evaluation, because sometimes what needs to be taken care of first is the cause that makes the recurrence, like in this case, smoking or obesity, number 1. And number 2, when patients get a lot more repair, sometimes you have a very bad quality of tissue that you ended up with. And some of those patients have to go to the last resort of hernia repair, which is called an abdominal wall reconstruction, which is a different, it's a more deep topic than this. But it's basically, we have to reconstruct all the muscles from the abdominal wall. So I hope that answered that question, but.
What is the downtime to repair a hiatal hernia?
Good. So the downtime, if the hernia is done through a minimally invasive approach, which once again, majority of the surgeons in this country are doing it that way. I usually tell my patients, you're going to be out of your duties for a week. After that week, if you feel fine, and that means fine, minimal pain, and you can eat without any problems, then you can return to your normal living activities, with the exception of 2 things. 1, can't lift anything heavier than 30 pounds for 6 weeks. And the reason is when we fix out a hernia, we put sutures to approximate the muscles. Sometimes I put a mesh, sometimes I don't. And your body takes around 6 weeks to heal 80% of the process of healing. So we want to be sure that healing process, your own body's building those cells to make things as normal as possible, that there's no tension in that repair. So I tell my patients, no lifting more than 30 pounds for 6 weeks and no bending over. Bending over will put pressure into the repair. But that's basically it. 1 week out and 6 weeks, no lifting and no bending over.
Okay, and somebody else said, my abdominal hernia has come back, no obese, and they don't smoke. They have no pain, just unsightly. Should I try to correct it again?
The answer is yes. And the answer is yes for the following reasons. Hernias that recur, especially if they have a mesh in there, they have a high chance to create complications of hernias. What are the complications of hernia? Number 1 is called incarceration. That means you have the hernia in the hole, whatever organ is coming through that hole. In this case, it's the abdominal wall, piece of the intestine. They can get stuck in that hole. That's called incarceration, like being incarcerated in jail, can't go anywhere. And the second complication is strangulation, strangulating somebody. So the blood supply to whatever organ is in that hernia, it gets cut off. And that is when it becomes an emergency. And that is what people out there, community says, oh, he busted his hernia, which is basically you had a piece of dead intestine. And at that time, you had to go in an emergency, cut the piece of intestine out, put it together. At that time, that field is infected. You cannot put a mesh. Probably just put sutures to fix the hole, and we just talked about it. Put in sutures. In a hernia, it has a 50% chance to come back. And if this is a recurrence, then the recurrence, I mean, if this is a recurrence that already had the hernia happen again, then the chances for recurrence are going to be even higher than that. So the answer is yes, because of this situation. You don't want it to come into an emergency. And if you got it already fixed and you have a mesh, most likely will become a problem in the future.
Okay, well, if there's not any other questions, I think that is it. Dr. Espinel, thank you so much for joining us tonight.
Hey, well, thank you very much, Hannah, for putting this together. And thank you, everybody, for listening, and hope this has been a little bit educational for everybody.
Yes, thank you everybody for coming on tonight, and please continue to check out our classes on tanner.org, classes and events for other informative topics. Everyone have a great evening.
Bye-bye.